Assalamu alaikum. Today's case is the right-sided pelvic-ureteric junction obstruction. The colon has been mobilized, the ureter has been identified, we have dissected the pelvis all around, and now we are dissecting the area which we will resect from the pelvis. Here a very narrow segment can be seen, and we will cut just below that narrow segment. Here you can see that narrow segment, so we'll just cut below that and we'll confirm that there is no urine coming out of the renal pelvis, which confirms the PUJ obstruction. And then we will spatulate the ureter for a good 2 to 2.5 centimeters, and then we'll cut the pelvis. Here, after cutting the pelvis, you can see that urine is pouring out, and the pelvis is thick-walled, which also confirms the diagnosis to be pelvic-ureteric junction obstruction. Care must be taken not to over-resect, because there is no need to resect the pelvis too much in this case, because the pelvis size is quite reasonable. Both the edges should be cut in the same manner, and after that we will see whether the corner is coming. Yes, so they can be approximated very easily without any tension. And then we begin the anastomosis with the 4O vicryl. So I take the stitch from the lower corner, and then from at the corner of the ureter, and both can be easily approximated. So once again, as before, we have discussed the principles of pyeloplasty. This is basically Anderson-Haynes pyeloplasty. Anderson-Haynes pyeloplasty is a dismembered pyeloplasty, which is one of the largest number of pyeloplasties performed. In this, we resect the segment of the ureter which is deficient of muscles and does not have peristalsis. So those peristalsis can lead to lack of peristalsis leads to obstruction. So that pathological segment needs to be resected. And now we start the anastomosis of the posterior wall, what they would call in open surgery the posterior wall. So initially, in a few stitches, a very accurate margins of the ureter need to be taken into the stitches. Mucosa to mucosa approximation is really very necessary for it to be watertight. So the Anderson-Haynes pyeloplasty initially was designed for the lower polar aberrant, the so-called aberrant vessels. However, it gained popularity over a period of time because it addresses the pathological segment as compared to other non-dismembered pyeloplasties, which do not address the strictured or the non-peristaltic segment. And so this form of pyeloplasty has got the best of results. So we are always trying to follow this form of pyeloplasty. The principles of pyeloplasty are the same whether you perform it in an open approach, or the laparoscopic approach, or the robotic approach. First of all, resect the diseased segment. Second of all, try to maintain the vascularity of both the pelvis as well as the ureter, especially the ureter, because that will be mobilized. The pelvis gets its supply from the kidney, which is very vascular, but the proximal ureter, after dismembering, the blood supply can be compromised. So mobilization of the ureter has to be in a fashion that it is not denuded completely of the periureteral sheath, which contains the vessels running parallel to the ureter, and they ensure the vascularity. Then the anastomosis has to be in the dependent area, because if it's not in the dependent area, then there is again a chance of PUJ obstruction and failure of the procedure. Then the anastomosis has to be tension free. In this case, if you have resected a lot of pelvis, especially the margin of the pelvis along the lower border of the kidney, lower pole of the kidney, then it's difficult to approximate the ureter and the pelvis, so that will lead to tension on the anastomosis. Here you can see that we have taken the suture out, and now we will create a loop outside the anastomosis, and then we will take another stitch, so the suture will be outside the anastomosis, and hence the knot will be outside the anastomosis. So talking of the principles of pyeloplasty, there should be no tension, and it should be watertight, and it should be adequately drained by a TG stent or a nephrostomy tube, and the redundant pelvis, if any, has to be resected so that the system is not atonic. So here I think the vascularity, I'm really very happy about it. The ends of the ureter as well as the edges of the cut pelvis, they are both having nice blood supply with a little bleed as well, which is making the field a little dirty, but instead of worrying for it, I am really happy for it. So anastomosis of the posterior aspect and the posterior wall of the pyeloplasty is complete now, and then I place my 2 millimeter port, which is in line with the ureter, for it to be able to hold the ureter in line or in parallel to the ureter. So a glide wire is placed into the bladder, and over that guide wire the stent is pushed, and then we push the needle or that 2 millimeter port very near to the PUJ, so that the stent can be pushed easily into the system, and then we take out that port and the glide wire, and we place the loop of the stent inside the renal pelvis. At times it becomes really annoying, but you have to push it really well into the pelvis. So then the anastomosis of the anterior wall is started with the stitch in the corner. Corner needs to be cleaned. Here we have seen the DJ stent. So it is a nice strong stitch taken into the corner of the anastomosis. The stitches in the corner are really very important, because they are going to decide the outcome of the pyeloplasty. So they have to be taken with good care. It doesn't matter whether you are performing a continuous suture or interrupted suture. Some surgeons prefer to take interrupted sutures initially near to the corner, 2 or 3 stitches, and then the rest of the anastomosis is continuous suture. You can perform with whatever you are comfortable with. I have no problems doing the continuous sutures, so I will do the continuous suturing. So with this suture, we will reach up to the tip of the ureteropelvic anastomosis, and after we are done with the ureteric and pelvic anastomosis on the anterior wall as well, we may continue to stitch with the same suture up to the tip of the pelvis, or it's our choice whether we will continue and do the remaining pelvis from above downwards. Here I take the loop of the previous suture into that suture's loop so that we know that both of them are opposing each other, and then we will knot it. You can knot it, you can even interlock it and then continue with the same suture. It's up to you, so long as the principles are followed. There's nothing wrong with any modification. So we decided to continue our suturing from above downwards. There's nothing wrong with it, as we are observing the principles of watertight, tension-free, good vascular supply, free drainage by the DJ stent, excision of the excessive pelvis, and in the end we will place a drain in the pelvis because it's a transperitoneal procedure, and we will place a catheter. So after this stitch, we would like and prefer to excise the remaining portion of the PUJ. The drain will remain there for 24 hours. So if it doesn't drain anything significantly, we can remove the drain after 24 hours and send the patient home with the catheter. The catheter will remain there for a minimum of 1 week and a maximum of 10 days, so that the patient does not develop any intrarenal or intrapelvic pressure while micturating and making the anastomosis leak. So after a week, when the anastomosis has sealed, we'll remove his catheter, and the DJ stent can remain there for another 3 weeks. Thank you very much for watching, and enjoy the procedure.